Hey guys, am I audible, visible? A very good evening, and hopefully your the week started well, and hopefully the week will end well as well. Fine. So today we'll be going with quick revision of GIT. I had given the chapter to be read in the both in the WhatsApp and the Instagram channels. Hello, Lion. Good evening. So what I'll do is only we'll cover like 4 or 5 major topics in GIT today. If it's okay for you guys, can we have something in liver and pancreas somewhere in the evenings or afternoons of subsequent days? Because I don't have any Farre, I think so, for the coming week. Because there's 3 subjects, I cannot get complete everything. If it's possible, we'll try to cover that out of this routine syllabus. We'll try to take tiny breaks of from your routine of microbiology and pharmacology. We'll cover a little bit of extra pathology as well. Fine. Okay, great. Good evening, Brajesh. Good evening, Devaka. Okay, let's start. So we had discussed. I had put major topics in the groups of in the GIT. We are going to cover about colon cancers, gastric cancers, peptic ulcer disease is definitely a very important one, which I'm sure you must have guys have got that in the send-ups and multiple previous year question paper, and also a little bit information about inflammatory bowel disease. Fine. Okay. Sure, I'll try to do it. Okay. Perfect. Fine. So now the neoplastic condition template is going to be the same. We will not change any template of neoplastic conditions. We have used the same thing for lung cancer. We'll use the same thing for colon gastric cancer also. Etiology, risk factors. Whenever we talk about etiology, there are 2 things which are mandatory. One, a sporadic etiology, a sporadic risk factor, and if possible, a genetic history or a syndromic etiology or a syndromic risk factor is must. Then pathogenesis and progression. If there is no particular progression of adenoma carcinoma sequences, we'll just stick to the pathogenesis part. Okay, this is going to cause mutation and is going to cause. But in colon and gastric cancer, we do have a progression, then we'll definitely go into that as well. Fine. Appendix Pranjal, I am not sure appendix is there in your CBME curriculum at all. Appendix is appendicitis primarily. Fine. And appendicular tumors are not a part for UG curriculum at all. Fine. Okay. And then we'll go to clinical history based on the disease, based on the structure. I'm sure you can easily write a clinical history for stomach or colonic cancer without any difficulties. Gross, every epithelial carcinoma, gross has ulceroproliferative, infiltrative, and ulcerative subtypes, and we can definitely draw. When it becomes to colon cancer, the same ulceroproliferative infiltrative will have a different outcome. We'll look at that as well. Fine. Then microscopy and progression. All these tumors in the entire JD, what tumor it will be? Will it be squamous? Will it be adeno? Will it be neuroendocrine? Predominant of them is going to be undoubtedly a squamous cell carcinoma. Sorry, adenocarcinoma. Right? All of them are gland-forming tumors throughout the entire GIT, maybe except for the little bit of esophagus in the top part and the anal canal. Rest everything is going to be adenocarcinoma by default. Right? Perfect. Great. So then about prognosis a little bit. Okay. Perfect. So now let's go to the neoplastic conditions. Whatever we have to read about it. Just give me a second. Yeah. Okay. So first thing is about stomach cancer. Sporadic etiology for stomach cancer. Can anyone tell me what all the sporadic etiology which can come into your mind for stomach cancer? Anything which comes across your mind. I'm sure you must have known about that. Fine. Okay. Definitely, Brajesh. It's just an output here. We'll definitely cover the gastric carcinoma or stomach cancers. Good evening, Ashish. One of the commonest etiologies, H. pylori. If I'm going to write as a risk factor, any infection should be the word having chronic, right? It's always a chronic H. pylori infection. Yes, CDH1 loss is not a sporadic thing, Samantha. It's an inherited or genetic condition, right? So it's an inherited or genetic condition. It's not a sporadic condition. Just give me a second. Okay, perfect. Antacid use, yes, to some extent can be there. Smoked food, that's definitely there. Nitrated foods, smoked foods will definitely increase the risk of gastric carcinoma or the entire GI cancer. H. pylori, indirectly it has to be in chronic H. pylori gastritis. The word chronicity is very, very important. Only chronic H. pylori gastritis will increase the risk of stomach cancer or that part, any chronic gastritis. It could be in chronic autoimmune gastritis also. Slightly, there will be an increase in risk of gastric adenocarcinomas, right? Any chronic gastritis for that matter, not just H. pylori, could be an autoimmune, could be in bile reflux and partial gastrectomy. Whenever you remove the stomach as a part of some other disease, especially the pylorus region, the sphincteric action is gone. This will result in bile reflux. This again will cause a chronic gastritis indirectly, which causes that. Fine. Okay. So which also increase the risk of sporadic carcinoma of stomach. Then I'll come to syndromic. The major syndrome, like Samantha said, we are going to concentrate on the CDH1 mutation, which gives a familial carcinoma, gastric carcinoma syndrome. In addition to that, HNPCC or your FAP can also primarily increase the risk to some extent. Not as much as CDH1. FAP and HNPC also can have an increased risk of stomach cancer because they are involved throughout the intestine, more towards colon, but little bit more to stomach as well. Lee-Fromney syndrome, what mutation? Lee-Fromney syndrome is due to TP53 mutation, which also can increase the risk of stomach carcinoma, right? But the most important thing here is this, the CDH1 mutation, right? That's the most important thing here, right? So now we know a little bit about the etiology. We know about the sporadic, we know about the syndromic as well, right? Lion retinoblastoma is congenital retinoblastoma syndrome, right? It's P53, which is a Lee-Fromney syndrome, fine? Okay, so once etiology is done, we have to give an output of how this etiology is going to cause a cancer. One is sporadic. Sporadic is very simple. Whatever may be the sporadic etiology, it's going to cause recurrent damage. Whenever there's a recurrent damage, be it the form of chronic gastritis, be it the form of smoked food, right? The smoked food is also a carcinogen. The smoked food is nothing but carbon, which also will cause recurrent damage. Whenever there's recurrent damage, there'll be increased exposure to reactive oxygen species. That by default, you know that it can cause mutation. Whenever there's mutation, it also can by default result in carcinoma. It will definitely cause carcinoma. That's how most of the sporadic etiology work. At the same time, include in the side itself how a syndromic etiology will cause cancer. Need not have a separate thing writing, but if you want to increase the page, please go ahead and write with separately as well, right? Syndromic etiology, the primary one for me is CDH1 loss. CDH1 loss or the loss of function mutation. What protein does CDH1 code? I'm sure you guys have known about that. What protein they code for? E-cadherin, right? CDH1 loss will reduce your E-cadherin expression. So when E-cadherin expression is gone, there are two things here. One, obviously they'll become dispersed. That's not the one which causes the cancer, right? Dispersion will cause the discohesion, that's all. So what causes cancer in E-cadherin loss is the loss of contact inhibition. This word is very, very important. You'll have loss of contact inhibition. Normally when there's a contact, there'll be inhibition to growth, right? So there's a loss of contact inhibition, which is obviously going to increase the growth of the cells or increase the cell division. That causes the cancer. Loss of contact inhibition is the reason for carcinoma, and the spread is the different thing, fine? Okay, so here this will increase the cell division. When there's increased cell division, by default it will also result in carcinoma. I'm not primarily writing what type of cancer does it cause. If you want to write, mention here itself. One causes diffuse type of gastric carcinoma, there's a CDH1 loss. Other one causes predominantly intestinal type of gastric cancer, that's a normal gastric adenocarcinoma. Does not require, since it's pathogenesis, let's have a common pathogenesis, right? So my etiology is done, little bit of risk factors, pathogenesis is done, right? Now I want you to talk about clinical features. Can anyone tell me what will be the clinical features of gastric cancer? See, one biggest thing about second year is at the end of second year, you must have seen most of the cases in your wards if you've been to your wards. What do you think will be the clinical feature? Clinical feature, the long-standing gastritis itself is a history, right? You might have symptoms of a long-standing gastric ulcer. Vomiting can be there. Gastric bleeding can also be there, right? Not very prominent. Subtle bleeding can be there, but long-standing gastric history is one. In worst case scenario, I am sure you guys must have presented gastric outlet obstruction. Have you presented case of gastric outlet obstruction? In gastric outlet obstruction is where, like Lion said, vomiting could be the presenting feature. When the outlet is obstructed, appetite will not be there, loss of appetite and loss of weight, early satiety, perfect, right? So early satiety can also be there, especially in case of an diffuse type of adenocarcinoma, and loss of weight, loss of appetite, especially in advanced stage, right? Can anyone tell me, add what is a Trossier's sign? Because this could be the history given in a long answer. Trossier's sign is a classical finding seen in gastric carcinoma where you have an enlargement of one particular lymph node. What lymph node is that? The lymph node is called as Virchow's node. Perfect. You have the left supraclavicular lymph node enlargement. So we call it an Virchow's node. So Virchow's node enlargement is mentioned as Trossier's sign. Okay, left supraclavicular lymph node enlargement. This could be the presenting feature. Elderly person, loss of weight, loss of appetite. On examination, found the left supraclavicular lymph node. What could be the probable diagnosis? This also can present, right? What is the umbilical nodule name? Umbilical nodule can also, umbilicus also can receive the metastatic deposit. We have the Sister Mary Joseph nodules, right? So umbilical nodule can also be the presenting feature, though rare, but this can definitely come in an exam. That is most likely the presenting feature of gastric carcinoma, because you cannot palpate a mass in the stomach unless it is going to be very big and huge. You'll not be able to do anything. So metastasis presents primarily, fine. Okay, these could be the most likely. Caput medusae is different. That also happens in the umbilicus, which happens in cirrhosis, Samantha. It's just a nodule. It's just a skin metastatic deposit of a gastric cancer. Symptoms are sorted. So how do you investigate? Whenever you write symptoms, please include one more thing: lab or investigation, right? So if you have a suspected patient with a gastric cancer, how do you investigate? Investigation is simple, right? You put a endoscopy. You put an endoscopy. If you want to be very specific, write UGI endoscopy, upper gastrointestinal tract endoscopy, and then you take a biopsy. Wherever there is a suspected area, you take a biopsy. That's more than enough. If you want to add a little more, take a CT scan or an endoscopic ultrasound for you to stage the tumor, to look at the celiac lymph node involvement. It might be required, especially to stage the tumor. Primarily it's not required, but to stage the tumor, it might be definitely required. These are the investigations one will do. This is just for the extra marks, not required, but I'm sure you must have had good amount of idea of how to evaluate a patient, right? So like that, you can definitely add about it, right? Now we know the gross. Gross is simple. What are the things in gross? Any adenocarcinoma or any epithelial cancer, I'm going to have the same thing. I'll have an ulcerative, ulceroproliferative lesions, right? Okay, I'll have an ulcerative and an ulceroproliferative lesions, and also an infiltrative lesion. That's how it's going to be there, right? Samantha, I'll try to do it sometimes later. Now let's concentrate on GIT. Right? Site, the predominant site is going to be pyloric antrum. This is the most common subtype, most common site where you can have. You can have the tumor also in the lesser curvature of the stomach. That also is possible, right? By pyloric antrum is undoubtedly common one. Gross types, again, I have an ulceroproliferative lesion. So in ulceroproliferative lesion, rather than just writing ulceroproliferative, if possible, put a diagram. I'm sure you can easily draw a diagram where you can see an ulceroproliferative lesion, right? One important thing is, in stomach, it's very important for you to differentiate benign ulcers and malignant ulcers. That's a standard viva question which will come in your exam. Or you can even have if you have 3 marks or 2 marks, you might have the difference between benign and malignant gastric ulcer. Instead of just writing ulceroproliferative, write a few more words. Okay, ulceroproliferative, where the size of the ulcer is generally more than 3 or 4 centimeters, pointing to a malignancy. The most characteristic findings in heaped up margin. If you have this word, that's more than enough for you to say, okay, this person is definitely considering of an underlying desmoplasia. So it's a very heaped up is just protruding margin. So it's most likely a malignant ulcer. That's how every malignant gastric ulcer will look like, right? At the same time, the second type here is ulceroinfiltrative. So the infiltrative subtype, what's the gross term named as? I'm sure you guys know that. It's infiltrative. What do we call it? We call it, perfect, we call it linitis plastica. There, draw a very thick wall stomach. If you have good diagrams, if you can draw good diagrams, that will be great. Or just a representative diagram. The entire stomach wall has become thicker, a leather bottle appearance, or a linitis plastica. Okay, this is due to underlying desmoplasia and infiltration of the tumor cells across the entire wall of the stomach, right? Or a leather bottle appearance. So there are 2 primary gross findings, and obviously I'll have multiple microscopic findings, right? What are the microscopic findings? How do you classify the gastric cancer microscopically? I'm sure you know one classification. I wanted to introduce 2 classifications, though we have read both of them separately, but we'll try to kind of combine both of them together here. One is intestinal type gastric cancer, other one is diffuse type gastric cancer, right? It's as simple as that. Intestinal type will look like classically like a classical adenocarcinoma. You will have the glands, 4 features of dysplasia, invasion into lamina propria, right? So when you look at the types of them, Lauren classification is the name. So based on the Lauren, and the reason WHO is also based on Lawrence only, I have 2 major subtypes. One is intestinal type gastric cancer, and the other one is diffuse type of gastric cancer, right? Perfect. Okay, so intestinal type of gastric cancer, what will they have? Will have a classical tumor of an adenocarcinoma. Good evening, Plexer. Any adenocarcinoma, Template is same, right? So see, we have templates. Be very confident and go to the exam. Adenocarcinoma, any question comes, these 4 words, if you write, you will never go wrong. You will have glands by default. You will have all the 4 features of dysplasia by default. I'm not writing them. What are the 4 features? I'm sure you know your pleomorphism, high NC ratio, mitosis, loss of polarity. You should have invasion, right? Here, invasion is for me the lining next to my epithelium. What's the layer called as? Here, I don't have dermis like skin. It's GIT. What's a layer next to the epithelium called as? Okay, I'll have invasion here into lamina propria. Invasion into lamina propria, that's basement membrane primarily. Below the basement membrane, I have a structure called as a lamina propria. It goes into that. We call it invasion, right? Again, if you want to draw a diagram, it's very easy to draw a diagram. Whenever you're drawing any diagram, please try to incorporate normal appearance if possible, because you might think like an abnormal gland and draw something. It might not look abnormal for the examiner, right? So it's easy. Divide them here. Draw a normal gland. Can I say the glands here is made of columnar epithelium? Is that statement right? So if it's columnar epithelium, draw them like this. A normal gland with a basal nuclei. Okay. Every columnar epithelium is going to have a basal nuclei. So draw a basal nuclei like this. That's one, right? So next thing, when you draw a adenocarcinomatous gland, loss of polarity, very huge nuclei, irregular shaped glands, single cells, and draw a little bit of pink color tissue for the desmoplasia, right? Obviously that will be there. That will sort out, right? It's a very small and ugly diagram. Please draw a better diagram in your exam, right? Today Nitesh. Okay. Then next comes to diffuse type of adenocarcinoma. The diffuse type of adenocarcinoma, what's a microscopic finding? Open up, come on. In the fag end of the year, I want you guys to answer. So it's more of a conversation than a one-line teaching, right? What's the type of microscopic finding in diffuse type of adenocarcinoma? Great, yeah, that's a signet ring morphology, right? If you want, write how signet ring looks like, or if you want to give a build-up, right? Indirectly say there'll be no gland formation, there'll be no ducts formation in case of a diffuse type of adenocarcinoma. Microscopically, you'll have a diffuse infiltration or sheets of signet ring cells. Okay, so signet ring cell is very simple to draw. Draw a cell with a nucleus to the corner, multiple cells to nucleus to the corner, and the most important thing here, don't forget to mark. The reason why it is of signet ring morphology is it's filled with intracellular mucin. So I'm going to have intracellular mucin. That's why the morphology is signet ring shape. That's more important. Fine. No. Okay. I am also Desi only, Nitesh. Don't worry about it. Fine. Okay. So that's the classical Lauren or the WHO types of gastric adenocarcinomas, right? There's one more difference called in microscopic types based on invasion of tissues. So invasion, we have the TNM classification. That's one. We did read about something called an early and late type of gastric adenocarcinoma. Can anyone remember that? How do you classify early and late? So based on invasion, there's primarily a Japanese classification. We call something as an early gastric cancer and we call something as a late gastric cancer, right? Though it's not much accepted outside Japan, but this is there in the textbooks. It's good for us to write, right? By default, every carcinoma is staged based on TNM only. If the cancer is limited to mucosa and submucosa without involving lymph nodes, sometimes might involve lymph nodes, we call it an early gastric cancer, right? Tumor limited to mucosa and submucosa involved, we call it early gastric cancer. If the tumor is beyond the submucosa, we call it late gastric cancer, right? So we call it late gastric cancer and we call it an early gastric cancer. Again, just a way to end it, right? That's all. Immunohistochemistry is not required here because it is very easy to differentiate on a light microscopy. If want, write the marker. What's the marker for upper GIT? Cytokeratin 7. That's a classical marker for an upper GIT, right? Now, again, always you have to end with prognosis. Management and prognosis is by default required, right? What do you think is a treatment for gastric cancer? Anyone? Treatment for gastric cancer. Treatment by default is the same, right? You're going to do a surgical removal of the stomach. Can be a partial gastrectomy or a total gastrectomy based on the involvement of the lesion, whether it's in the pylorus only or in the body, and based on the involvement of the lymph node, right? Second, prognosis. Which will have a better prognosis? Intestinal type will have a good prognosis by default. Because of diffuse gastric cancer, it can definitely spread a lot. It can go and involve the ovary. It can present as Kuchenberg's tumor, right? So intestinal type gastric cancer has a better prognosis compared to your diffuse type of gastric cancer. That will end the story of gastric carcinoma. Have a template always. Some of you might have got the send-ups now, right? So while having the send-ups also, please, any question when it's asked, think for a minute. Make sure you have at least 4-5 headings. That's enough. Every heading you write two points, it's enough for me. If you write 2 right points for every heading, which is 10-12 points, that's more than enough for a 5-mark question. You need not write pages. Like I said at the start, if you don't know this stuff, write pages. If you know this stuff, restrict yourself. Fine. Let's go to colon cancers. Same template. We'll have the risk factor, etiology, sporadic and syndromic. We'll look a little bit about the pathogenesis. Here, adenoma carcinoma sequence is very, very important. Then we look at the clinical history and how to diagnose. Then microscopic types if required, and the prognosis and markers if required, right? Can anyone tell me what will be the risk factors for colonic carcinoma? Not syndromic, sporadic. Anything which comes to your mind for sporadic risk factors for colonic carcinoma? Sporadic risk factors? By default, a low fiber diet and a diet rich in excess of fat, also carbohydrates. That's one. Alcohol is not the primary risk factor for colonic carcinoma. This combination of low fiber diet plus a high intake of fat, especially red meat or fat, you can write red meat itself, right? Red meat is the most important risk factor for colonic carcinomas. Smoked food also. Alcohol will definitely be a stimulant. It's not the primary reason. It can definitely have an additive effect, right? Syndromic, at least mention these 2 syndromes. So something basics. If you want to score more, you know many syndromes. Can anyone tell any other syndrome which can cause colonic cancer? You can write them also, because all of them, all of the polyposis syndrome will definitely increase risk of colonic cancer. Any other syndromes? We have multiple of them, right? We have your Peutz-Jeghers syndrome. If it's Peutz-Jeghers syndrome, if you want to write extra about the pathogenesis, write about the pathogenesis. We have juvenile polyposis syndrome. Okay, that also we can write extra, right? We have juvenile polyposis syndrome. I'm sure you must have read about P10 hematomatous syndrome. Perfect, right? There are multiple syndromes. P10 hematomatous, the Cowden syndrome will come under that. All of them, right? Perfect. GARD and Turcot. GARD and Turcot's a variation of FAP. So FAP should be more than enough for me. Syndromic approach of colonic cancer is actually bigger than the sporadic risk factor. Again, it's not must to explain all of them, but if you can mention them, that's great. If possible, write the gene also involved simultaneously next to it. Need not explain much. Okay, Peutz-Jeghers syndrome, I think of an STK11 gene. That's a gene here which is mutated. Juvenile polyposis syndrome, we have a gene called as SMAD4 mutation, right? That's a gene which is getting mutated. Cowden and P10 hematomatous, as the name says, P10 is going to get mutated here, right? Just a name over there. Gardner-Turcot is a variant of FAP. So what's the gene involved in FAP? Anyone? Though we'll read them in detail soon. So FAP, we're going to have APC, right? The APC gene mutation is going to be there. And in HNPCC, you'll have methyl mismatch repair. Fine. Namaskar, Pratik. So you'll have methyl mismatch repair. That is for HNPCC, right? All these syndromes are just required for the naming. If you can involve FAP and HNPCC, those are the primary 2 things which will involve the pathogenesis, right? And also sporadic risk factor. Now we look at the pathogenesis of FAP and HNPCC separately. Then we look at the adenoma carcinoma sequence. There are 2 things in pathogenesis. One, we'll understand how FAP and HNPCC cause cancer. Then we'll have a look at that, how they will convert a normal mucosa into a cancer, right? The first thing about FAP. FAP, you're going to have an APC's loss of function mutation. That's how it is going to be. So normal APC will hold a protein called as beta catenin. They will bind with beta catenin or they will inactivate beta catenin. Instead of writing holding, just write they will inactivate beta catenin. So when you have loss of function of APC, so APC is lost, which will result in overactivation of beta catenin. So this beta catenin is going to go to the nucleus. It's a transcription factor. It will increase the cell division. So when there's more cell division, by default, anyone knows that it will end up in only 1%, which is carcinoma. Okay. So if you are writing shortly, if you can draw diagrams, great. If you're not able to draw diagrams, write in words, that also is great. Drawing diagrams consumes space. Writing words will not consume space. Fine. Autosomal dominant, Punit. Almost every cancer syndrome is autosomal dominant inheritance. Fine. Okay. Now let's have a look at HNPCC. So HNPCC, the most important thing right here itself, they are more involved in right side colon cancers. That's a classical thing. History wise also, when I have right side colonic tumors, I think of a HNPCC related problem. Here I'm going to have a mismatch repair defect. So when I have mismatch repair defect, so by default it's self-explanatory, which is going to accumulate or increase the DNA errors, or the DNA errors are not being corrected, it accumulates. That by default will cause more and more mutation, more and more cell division, which will definitely by default result in carcinoma, right? So it's going to accumulate. It's like P53. It's going to have more and more and more errors, which primarily is going to result in adenocarcinomas, right? So that's how the normal thing is. Now I'm going to have a adenoma carcinoma sequence. So I have one type of adenoma carcinoma transition here and one more type of adenoma carcinoma transition here. This sequence is very important for two reasons. One, it will talk about the progression or the precursor lesion. In cervix, we had normal CAN1, 2, 3 cervical cancer. Like that, for FAP, I'll have normal adenoma carcinoma. For HNPCC, I'll have normal serrated adenoma carcinoma. So the precursor lesion differs here, fine. So if you look at the adenoma carcinoma sequence, let's assume it's a normal mucosa here. To the normal mucosa, again, you not write everything. Few genes are more than enough, right? So let's assume it's an APC. Can anyone help me here? APC is a tumor suppressor gene or proto-oncogene? No, Vamish, they are all inherited syndromes, right? Both of them will result in cancer formation. It will have adenomas. It can become a carcinoma based on the second hit present or not, because all these are tumor suppressor genes. All of them are tumor suppressor genes. Again, remember, most of the cancer syndromes are autosomal dominant and most of them are tumor suppressor genes. And tumor suppressor gene always will have two hits, right? So they have first hit, okay? First hit of the APC. We must have read about the Knudsen's 2-hit hypothesis in retinoblastoma, right? I'm sure you remember that, right? This makes the mucosa at risk. The mucosa will be at risk. It's not yet a tumor, right? I need a second hit. So APC is second hit, or I have a beta catenin mutation. Something should be there, right? When I have that, it becomes an adenoma. So adenoma is not a cancer, it's a benign tumor. That's why FAP can have hundreds of adenomas in the colon. They will not form a carcinoma unless I have more and more mutations, right? So to form from adenoma to carcinoma, I need more mutations like KRAS should be there. I need TP53 mutation, then it might become a carcinoma. So once it becomes a carcinoma, in order to metastasize, it might require telomerase activation. Okay, so finally I'll have a telomerase activation finally, right? So this word is important for me and this transition is important for me, right? It's an adenoma to carcinoma sequence from normal to abnormal. Perfect, right? That's for normal one. Second, I have same thing for HNPCC. The only thing is HNPCC is a little bit different from FAP. Still, it will be the same normal colon. I'll have the germline hit of your mismatch repair genes. So I'll have the mismatch repair genes mutated. If you are able to remember the mismatch repair genes, write them or just write them. The mismatch repair genes are undergoing mutation. That's enough. The genes are your MSH, MLH. If possible, write MSH and MLH. These are genes which is involved in the mismatch repair. They are getting mutated, right? So once they're getting mutated, instead of normal adenoma, it becomes something called a serrated adenoma. This is important. Serrated adenoma is different from a normal adenoma. The precursor of HNPC is different from a FAP. This will require further mutations. Like your one at least mutation I want you to remember is BRAF. BRAF mutation makes it a carcinoma. Again, carcinoma once it forms, you need a telomerase mutation for it to spread, right? The sequence is required because adenoma carcinoma sequence was first established in colonic cancer. Then only we did the same thing for gastric, same thing for your prostate, multiple places. We kind of extrapolated the adenoma carcinoma sequence. Serrated adenomas, the tumor has serrations. Microscopically, it will be like a comb, serrated. So we call it a serrated adenoma, right? That's why it's called as a serrated adenoma, fine. Okay. So we know about the pathogenesis, we know about the etiology. Clinical features, anyone? What do you think will be the feature of a colonic tumor? Whatever comes to your mind. I'm having a tumor in the GIT, in the colon, in the intestines. What do you think will be the features? One feature, never forget, this might be the history also. Elderly person coming up with an iron deficiency anemia, one of the first thing to remember is occult blood loss in the stool. Colonic cancer will not have frank blood loss in the stool. It's always occult blood loss, right? That's very, very important. Elderly with an occult blood loss resulting in IDA, think of your colonic cancer. That's by default. Vamish, I might not call it a melena. Melena is for generally an UGI bleeding. Colon cancer will not have an UGI bleeding, right? It's a lower gastrointestinal tract bleeding, right? And this altered bowel habits, altering constipation, diarrhea, not a normal bowel habit. It's called an altered bowel habits, and this is a very, very important clinical issue. Most of the time, they will present with that only. Okay, so loss of weight and loss of appetite will be there in every cancer in advanced stage. You do a colonoscopy, and then you do a biopsy if required. Again, you can write any of the MRI or CT scans for you to stage the tumor. It's required later on, fine. So once we did a biopsy, we come to gross. Gross, this also is an epithelial tumor. So can I say it can have the same lesion? It will have the same lesion. Ulceroproliferative, infiltrative, or ulcerative. That's all, right? So now here, so ulceroproliferative lesions. So let's assume this is a colon. Here, please draw a colon here and draw an ulceroproliferative lesion. It's just a proliferative lesion. Ulceroproliferative lesion can cause obstruction. If it's very, very big, they can cause obstruction. Fine. Now, ulceroinfiltrative something which gave to a name, a new name. We'll just remember, understand why there's a name like that, and it's very easy to remember as well, right? Ulceroinfiltrative is it's going to cause fibrosis. It's going to become like this, fine. The colon, because see this is the normal colon's area, it's infiltrative, right? It's infiltrating and causing fibrosis. It's becoming thicker. So the entire colon becomes thick because of the infiltration. It becomes thick, right? So this lesion, when you do a barium enema or something, it looks, the lumen looks like this. So because of this, it was called as an, how does it look like? A napkin ring lesion, right? That's a classical term in gross. It looks like a napkin ring. There's one more name for us called as an apple core lesion. It looks like an apple. Once you bite an apple completely, it will be a slender center part alone, right? Looks like an apple core lesion or a napkin ring lesion. These are terms. If you write this, that's more than enough for me. These are for extra points, that's all. It's same infiltrative, same proliferative. Based on the organ, it has a different appearance, that's all. Microscopy is very simple. Be it an FAP related adenocarcinoma or an HNPC related adenocarcinoma, microscopy or outcome is going to be the same. I'll have the same glands, you'll have the same 4 feet of dysplasia, and you'll have the same invasion. If you want to write one additional term, write that if it's HNPCC related tumors, there'll be abundant lymphocytic infiltration. When you have more lymphocytic infiltration close to the tumor, we generally think of an HNPCC related tumor. That's what is suggested. Not always. That's a clue for me to talk as HNPCC related tumor, right? IHCs. Can anyone tell me the IHC for lower GIT? Upper GIT, you said that it's CK7 positive. What's the marker for lower GIT? You know lower GIT, right? Upper GIT is CK7. Anything below the ligament of Treats, the marker is CK20 positive, right? And you have to write CK7 negative. This combination is important for me. There's one more marker called as CDX2, right? For an 818 is for hepatobiliary line, 20 is for lower GIT, 7 is for upper GIT, right? And just to add on, If required for an extra mark, you can write, you can do markers for microsatellite instability, right? The same MLH, MSH. This can also be done as IHC just to establish your HNPCC subtypes. If I think of a very high lymphocytic infiltration, I may do this to prove it's HNPC related so that the entire thing can be taken care of. If it's a young age tumor, definitely genetic analysis is must. If it's a 25, 30-year-old, we don't get a colonic customer. I need to do genetic analysis, be it an FAP or an HNPC, I have to prove them, and genetic counseling for the family members are required, right? Treatment, management is same. How do you treat colon cancers? Instead of writing surgery as such, try to give a name to the surgery. Colectomy, a colectomy or a hemicolectomy. Mostly a hemicolectomy only, based on the tumor extension where it is involved. We try to cut the colon, half of the colon will be removed and have a colostomy bag throughout life. That's what is going to happen. Most of the surgical management will have something called neoadjuvant chemotherapy. Neoadjuvant chemotherapy followed by surgery, because when you give chemotherapy, the entire tumor becomes smaller, right? That's why followed by surgery. Because there's a very high chance, if it's a younger person, of a syndromic etiology than a sporadic etiology, right? No one is going to get a colon carcinoma at 35 years old. Then, which means I have to tell the sibling, see, there's a problem. Please go for a regular follow-up. If it's there, let's do a prophylactic surgery. That's why and genetic analysis and genetic counseling is required if it's an early onset cancer. Fine. That's true for every cancer, be it breast cancer, colon cancer, any cancer. If it's early onset, always genetics is required. Fine. Okay. That's about your colonic carcinoma. Now let's go to inflammatory bowel disease. Okay, inflammatory bowel disease, the etiology of inflammatory bowel disease, we have to borrow from immunology chapter because an autoimmune disorder, that's all. There are few things which is required to learn from here. The rest of every template, we have to go from immunology chapter only, fine? So it's an immune mediated chronic intestinal inflammation that results from inappropriate mucosal immune activation. Just a word for definition. It's nothing but I'm just using the same words to say it's a long-term chronic autoimmune disorder, that's all. Two things. Hygiene hypothesis is definitely a good sporadic risk factor. Smoking and abnormal gut flora will definitely increase the risk of inflammatory bowel disease. At the same time, this is important. NOD2 and CART5, these are the genes which produce the abnormal immune response, or I have a mutation in that. And if you want, remember, write this or just write autophagy related genes are also mutated. That should be more than enough. So these are few risk factors. Now let's create a model with these risk factors. Why am I having destruction of the gut due to autoimmunity, right? So what happens here is, the first thing is your genetic thing. So it's NOD2 or your CART15, right? So NOD2 gene or the CART15 gene, once is mutated, it will result in excess entry of the bacterial flora in the lumen. Generally, bacterial flora will be in the lumen or in the intestinal mucosa, in the wall. It will be in the lumen, right? Increase entry of bacterial flora in the lumen into the mucosa. Generally, it will be on the surface of the mucosa. It will not penetrate the mucosa. These guys, the NOD2 is something which will protect them from penetrating the mucosa. Normally, it will be in the lumen. If it's mutated, there's no one to protect. The bacteria enters inside. Once the bacteria enters inside, by default, who will be there? Can I say I'll have antigen presenting cells? Here we call them as M cells. In the Peyer's patches, we have something called an M cell, which is nothing but an antigen presenting cell. They will try to engulf the bacteria. Once they engulf the bacteria, they'll present the antigen to whom? By default, they'll present the antigen to CD4 T cells. Now, CD4 T cells here has two outcomes. Generally, CD4 has three outcomes: TH1, TH2 and TH17. That's the outcome which we must have read in immunology chapter, right? TH1 results in what? TH1 results in granuloma formation. Whenever TH1 is activated, results in granuloma. So whatever we read in chronic inflammation, put that here. If you want to make it a long answer, make it a long answer. If you want to make it a short answer, make it a short answer. Fine. TH2 results in allergy. Right, perfect. TH17 results in acute on chronic inflammation, right? Line TH17 is acute on chronic, fine. Now here I have TH1 response. this will end up in having a granuloma formation. I'm just directly writing granuloma. If IBD is a long answer, write that. Interferon gamma comes, macrophage becomes an activated macrophage, forms the appearance of an elongated slipper-shaped cell, epithelial cells, giant cells will attract lymphocytes, forms a granuloma. So the short answer, Th1 activation results in a granuloma. Or I'll have Th17 activation, which results in acute on chronic inflammation. Both are required. So whatever be it Th1 or Th17, by default, this both will destroy the GIT or destroy the intestine. It's an immune mediated damage to intestine. Once it destroys the intestine, you're going to have the inflammatory bowel disease. I want you to remember this. If it's in a question also, write it clearly. There are two types of inflammatory bowel disease. What are they? We have Crohn's and we have ulcerative colitis, right? Which you think will have more of cryptapsis and cryptitis? Which you think will have more of cryptapsis? I'm sure you must have heard that, right? Cryptitis, cryptapsis. Cryptapsis is more on ulcerative colitis and granulomas are more on Crohn's disease, right? Crohn's will have a little bit more of granulomas, non-necrotizing granulomas, and ulcerative colitis has more of cryptitis, cryptapsis. So Crohn's disease, you have more of Th1 predominant than Th17. I'm not saying that I will never have cryptapsis and Crohn's, might have. Ulcerative colitis is more of Th17 than Th1. Right? That's why ulcerative colitis will not have a granuloma and Crohn's will have a granuloma, right? It's a simple way. The examiner should know that, okay, this person knows what is the difference between the two major disorder. It's based on T cell stimulation. If I'm going to stimulate more Th1, different disease, more Th17, a different disease, right? So now we have to write the table for ulcerative colitis and Crohn's. I'm sure we read the table in a very different way. If you have seen the regular videos, I want you to stick to the same way. We'll see, you will take time, right? Anyway, if you write a table, you're not going to write everything like a robo. You'll not write very fast. You'll write slowly only. That is enough. So the first word you write, automatically the second word will come to mind because everything is linked, right? Ulcerative colitis and Crohn's. The first thing is, which is transmural, which is superficial mucosal, because that's how we started the ulcerative colitis Crohn's table when we read, right? So Crohn's was always a transmural inflammation. Ulcerative colitis is a superficial mucosal inflammation. Okay, if it's transmural, one is superficial mucosal, right? One is colitis, one is Crohn's disease. So here the site of involvement is predominantly colon. It will predominantly involve colon, but here the site of involvement is anywhere the GIT, from oral cavity to anal mucosa. It can involve anywhere the GIT because that's how the disease is. One is very widespread, one is very, very restricted. Once you write colon, the second thing which should come to your mind is there is a possibility in ulcerative colitis, ileum can be involved. We call it a backwash ileitis or backwash ileal inflammation is possible. Obviously, it's possible, right? Because ulcerative colitis is limited and Crohn's is very huge. Crohn's is very, very extensive. So there should be skip lesions. Skip lesions are must here. Here, most of the time they are continuous lesions. They are continuous lesions. They'll involve the entire colon. There will not be any skip lesion, but Crohn's will undoubtedly have skip lesions, right? Again, transmural and superficial mucosal. Because of the transmural thing, you can have an ulcerative colitis. It's tissue destruction healing by fibrosis, right? You might have transmural tissue destruction, right, like this itself. So you can write easily. It can cause fistulas, it can cause fissures, it can cause sinuses. Once it heals by fibrosis, it will be going to form your stricture. Okay, Samantha, why backwashes involvement of ileum in a colonic lesion? Why skip is because very, very extensive. If it's not skipped, the patient dies in a day. Fine. Ulcerative colitis, because it's a superficial mucosal involvement, right, like this. So the normal mucosa at the edge of the colon, sorry, edge of the ulcer, right? So the normal mucosa at the edge of an ulcer, they look very, very big. What is this finding called as? We call it a Perfect. It looks like a polyp, but exactly not a polyp. We call it a pseudopolyp, right? Same. Since ulcerative colitis, like Samantha said, is complete and uniform and throughout, the entire mucosa will be gone. Since the entire mucosa is gone, I'll have something called an lead pipe appearance. Lead pipe appearance is due to destruction of the entire mucosa, which will definitely destroy the hostrations. So we'll have loss of hostrations. So because of loss of hostrations, you can have a lead pipe appearance. Again, here, since it's intermittent, I'll have fibrosis here, again intermittent. I'll have fibrosis here, again intermittent. I'll have fibrosis here. Because of this, it has an appearance called an host pipe appearance. Okay. That's also a classical finding. Intermittent involvement, we call it a host pipe appearance. Throughout involvement, throughout destruction, we call it a lead pipe appearance, right? This is one of the two major findings, right? So these are few findings which you already know. Whenever you are writing this difference, I want you to slowly write the difference in terms of the clinical manifestations also, fine? Because that's kind of complete. Ulcerative colitis involves colonic mucosa. Crohn's involves the entire GIT, which will have more of malabsorption symptoms. Obviously, symptomatology wise, both will have one classical symptomatology, but here malabsorption will be more here because that will maximum cause water malabsorption, colonic, right? So you'll have problems in the fat soluble vitamin deficiencies. That will be a problem here. Okay. So here not much of malabsorption. Here's got primarily going to be an altered diarrhea, dysentery. That will be the primary finding here. Altered bowel habits will be the primary finding in case of an ulcerative colitis, right? Crohn's disease, since it's superficial, since it is transmural involving throughout, serositis can be there, right? To protect the serositis, you will have serositis here. To protect the serositis, you'll have migration of fat, and we call it, what is it called as? Creeping pad of fat. Okay, you'll have here creeping pad of fat. Creeping pad of fat is nothing but the mesentery trying to cover the serosa. Creeping pad of fat will not be seen in ulcerative because it's not transmural, right? So obviously ulcerative colitis, there is a little bit of protection with smoking because smoking increases the mucus secretion, so it protects with smoking to some extent, right? Obviously Crohn's will be worse with smoking. Microscopy, most common finding here is, I'm writing NN. NN stands for non-necrotizing. We have non-necrotizing granulomas. Here primarily the classical finding is something called an basal plasmacytosis. In addition to that, a very classical finding here is your cryptitis and cryptapsis. Though it's more commonly seen in ulcerative colitis, here also you can write cryptitis, cryptapsis is possible, but it's not very common as seen in case of an ulcerative colitis, right? So can I say both of them can result in adenocarcinoma? Possible, not possible, because both of them are chronic recurrent damage and both of them can definitely result in an adenocarcinoma, right? So long-term risk, both of the thing in a long term, there's an increased risk of adenocarcinoma of colon, because by default both of them will have excess amount of reactive oxygen species, which will definitely cause more damage, more mutation. Both will cause increased risk of adenocarcinoma. Like Lion said, which will cause more of toxic megacolon. Toxic megacolon is primarily seen in case of an ulcerative colitis. It's not a finding seen in Crohn's because they ulcerative colitis, for some unknown reason, they destroy your mesenteric Meissner's Orbach plexus or the neural plexus. Because of the neural plexus destruction, so the entire bowel loop, let's assume this is the site of destruction, will become, the proximal loop will become dilated. The proximal loop dilatation is caused in toxic megacolon. Creeping pad of fat is nothing but a mesentery trying to protect the hollow viscus before rupture. That's caused in creeping pad of fat, fine? So these are the differences. We read them in the same order. Try to remember in the same order. The advantage of having a connection is, you know one, automatically the next will come into place. But spend time in remembering it. You can easily write an essay on ulcerative colitis and Crohn's. We know the risk factor, we know the pathogenesis, we know the symptomatology, right? So clinical features, two things. One is intestinal, other is extraintestinal. We have read about extraintestinal also. I'll definitely tell you, we have read in a different place. We'll try to compile it here, that's all. Intestinal primarily It's altered bowel habits. You won't have a normal bowel habit. It'll definitely be an altered bowel habits. In addition to this, dysentery, diarrhea with mucus is a very classical symptom of ulcerative colitis and Crohn's. That's how most of them. Non-specific symptoms of fever and everything can be there. Abdomen pains, recurrent attacks of dysentery, bloody diarrhea with mucus is a classical finding. Extraintestinal manifestations are common in both ulcerative colitis and Crohn's. A few things I'm sure we have read. Did we come across something called primary sclerosing cholangitis? Have you read that? Primary sclerosing cholangitis? Ulcerative or Crohn's? More common is seen in patients with ulcerative colitis, right? Because the entire ANCA antibodies can go from the GIT to the liver and cause damage, right? So I do have extraintestinal manifestations. One of them is in the liver. It's again both ulcerative colitis and Crohn's can have it, but predominantly more in Crohn's. In liver, we have something called primary sclerosing cholangitis seen in case of ulcerative colitis. Mostly seen in men with ulcerative colitis. It transfers and goes and destroys everything, right? You can have good amount of lesions in the eye. When you go to ophthalm, you will read them. Uveitis. Uveitis is common in both ulcerative colitis and Crohn's. Arthritis. This is also a little bit more common in ulcerative colitis and Crohn's, right? You can write any different types of arthritis. Skin lesions, few of the skin lesions, but at least this, don't forget, add two more things. Eye and joints are also involved. These are extraintestinal manifestations. Again, management. Do you have a short answer on management of ulcerative colitis in your pharmacology? You will have, right? The best thing about second year is this. You can easily write one page on any random disease given. You know the pathogenesis, you have microbiology, you have pharmacology. Write those drugs. You know more than what I need to know. Have you heard about a drug called as 5-amino salicylic acid? Alpha ASA? You must have, right? Probiotics, ASA is one. Steroids, immunosuppressions are more. I'm sure you can write at least 2 words on the management of inflammatory bowel disease. Worst case scenario, I need a surgical removal in order to prevent adenocarcinoma. That's how finally it is, fine. So you know the management. It has both medical management as well as surgical management. See, exam is only a mind game. You have to make sure the examiner understands you know the subject. Play the examiner, that's it. Put 2 headings, medical, surgical. 3 drugs in medical, surgical, resection, that's all. If there's a risk of a carcinoma, resect it so that the patient will not have a carcinoma. As simple as that. On regular follow is always important. That's about ulcerative colitis and Crohn's. Okay, next one, peptic ulcer disease. How many of your previous year university exam had this question, peptic ulcer disease? Quite a few university exams, they have history of peptic ulcer, and this is very common, right? Peptic ulcer is common, or gastric ulcer is common. The only problem with peptic ulcer disease is, yes, Samantha, it will definitely cause, right? Most of the university exam will have this, right? The only thing here is, I don't know what to write. Because peptic ulcer disease, should I write only peptic ulcer? Should I write H. pylori? Should I write everything? I don't know exactly what to write. So please read the question carefully. If they are not mentioning anything about urease positive breath test, I'm going to talk about peptic ulcer disease. If they are mentioning specifically urease is positive, then I'm going to talk about entirely about H. pylori. Because H. pylori gastritis is different from peptic ulcer disease. H. pylori can cause peptic ulcer, but both of them are not equal. If the question is on peptic ulcer disease, PUD is a condition where, is it gone? Just give me a second. Okay. It's a condition where you have the lining of the stomach or the duodenum broken by gastric acid and or pepsin. That's why it's peptic ulcer disease. I have 2 reasons for peptic ulcer disease. Either I should have an increased production of acid, or I should have reduced protective factors or reduced mucin. These are the only 2 times I can have the entire GI gastric content destroy the lining mucosa, right? Increased production of acid, you can write anything. Okay. Yes, Bhavya, it will cause. Like I said, H. pylori can cause peptic ulcer disease, but both of them are not the same. Fine. H. pylori will definitely cause, but both of them are not the same. Fine. So increase in acid can be due to smoking, an acute event. NSAIDs, I am sure you know why it causes. prostaglandins will be gone. Once prostaglandins are gone, you will not have the protective effect, obviously more of them, right? Alcohol, drugs, many other drugs including your NSAIDs. H. pylori, this is your tumor, right? Here you have gastrinomas. So gastrinomas will obviously produce more gastrin. More gastrin obviously will increase the acid production, will obviously cause peptic ulcer disease. Zollinger-Ellison syndrome is a inherited gastrinoma syndrome. This can have peptic ulcer throughout the intestine, not just stomach and duodenum, jejunum, ileum also can have ulcers here, right? Unknown location ulcers, recurring ulcers, non-healing peptic ulcer, think of Zollinger-Ellison syndrome, right? Reduced production, anything with ischemia causes it. Yes, Vamesh. Ischemia, shock is also related to ischemia, and an elderly by default, aging can reduce the mucin production. There's an increased risk of peptic ulcer in them, right? So again, we know the etiology. Okay, here writing about the pathogenesis, because there's nothing much to write about pathogenesis of peptic ulcer except for concentrating on this person. The rest everything is direct, right? Acid destroys epithelium, that's all. In one word, I'll finish the pathogenesis, right? If I want to write pathogenesis, maybe there I must have included one more slide. Just give me a second. Okay, so while writing the pathogen should focus on your H. pylori, because rest everything is the same thing, fine? No, urease blood test is positive only in case of a H. pylori, not in case of peptic ulcer disease, fine? So here, when you want to write the pathogenesis, it's simple. More increased acid secretion or more reduction in the mucin secretion is going to cause epithelial damage, which will undoubtedly cause the ulcer. That's your peptic ulcer disease, as simple as that, right? Now, so now, if it's going to be H. pylori, because H. pylori is something which we can talk a little bit about in the pathogenesis, because otherwise pathogenesis ends up very short. There's nothing to explain in the pathogenesis. Maybe you can explain like these parts. Okay, gastrinoma is more gastrin secretion. Smoking NSAID will cause more amount of your acid secretion because of PGE to everything will be gone. Drugs, same thing. Like smoking can cause vasoconstriction. You can explain to some extent, but not to a long extent, right? But H. pylori, I can definitely talk a little bit about that. So H. pylori causes patchy atrophic gastritis. H. pylori will definitely cause atrophic gastritis because it's an inflammation induced ulcer. It will destroy everything. When it's patchy atrophic gastritis, it will by default reduce my acid secretion. Okay. Yes, Samantha. So once it reduces acid secretion, what will be the effect on gastrin? I'm having reduced HCl because of gastric atrophy. So I'll have by default more amount of gastrin secretion. So the gastrin becomes more. By default, it will increase your HCl production. This HCl production will increase the epithelial damage, and this will cause an peptic ulcer disease, right? So in your H. pylori, it's the gastrin which is a reflux due to the atrophic gastritis causes peptic ulcer disease. Gastritis is different from peptic ulcer disease. Gastritis is inflammation of the surface mucosa. It's not an ulcer. When a mosquito bites my skin, it's also an inflammation, right? Only when I have a loss of my skin, I can call it ulcer. Otherwise, I cannot call the use term peptic ulcer or ulcer, right? By matter, right? So that's about the, in short, about the pathogenesis of the peptic ulcer disease, fine? So once we know that, clinical features. You will definitely know the clinical features. You must have been the patient or you must have seen the patient, right? Epigastric pain, burning sensation. Look at this term in your question. If the pain is aggravated by the food, most likely location is stomach. If the pain is relieved by the food, most likely location is duodenum. That's how it is, fine? Okay. So melena can be there if there is a bleeding from the peptic ulcer, which might call melena. Worst case of bleeding, especially if a gastroepiploic artery is involved, in worst case of bleeding, it can also cause hematemesis. Not always. Generally, tiny bleeding will cause melena. Extremely high quantity of bleeding can cause blood vomiting as well. Fine. Can anyone tell me what's the most common site of peptic ulcer? The common site of peptic ulcer? Common site of peptic ulcer is not the stomach, it's always the duodenum, right? The common site of peptic ulcer is duodenum. That's the most common site. It can happen in stomach. It can rarely happen in other parts of the intestine as well, right? So whenever you have a history of unusual locations, jejunum itself is an unusual location, right? Like jejunum, which is a very unusual location. If it's recurrent, if it's not treatable, normally gastric ulcers are easily treatable, right? If I'm not able to treat, if it's recurrent, if it's in an unusual location, always suspect a Zollinger-Ellison syndrome. Okay, because here I'm having a tumor releasing gastrin, a tumor releasing the acid secretion. Until and unless I remove the tumor, it will not come into play, right? This will be the history of Zollinger-Ellison syndrome. Unusual location, recurrent, and I'm not able to treat the gastric ulcer. Think of a Zollinger-Ellison syndrome, fine? Because food will increase the mucus secretion when the food passes the stomach, and when the food goes to the duodenum, in that way it increases. That's all. Mucus lines the ulcer, less symptom. That's all, right? Now look at the gross. Gross, again, there are multiple things which I want you to talk about. One is size and number. This is not very important, but it will be very tiny. It will not be more than 0.5 to 1 centimeter. Like I said, in the malignant ulcer, if something is more than 4 centimeter, I always think of a malignancy, where we saw that in the gastric carcinoma, right? Size, mostly solitary. If it's a simple peptic ulcer, mostly solitary. If it's multiple, again I think of Zollinger-Ellison syndrome if it's multiple, and it's 0.5 to 1 centimeter. It's never more than 3 or 4 centimeters. If it's more than 4 centimeter, very unlikely to be a benign ulcer, right? Next, shape. Most of the ulcer, see, this is the skin. Okay, let's assume a drop of ulcer drops on the skin. The shape will be round or punched out. That's how it's going to be, right? So it's going to be round or oval, because it's an ulcer damaging, and it will most likely be punched out. It looked like something has gone inside and eroded the area. That's how most of the peptic ulcers will look like, right? Margin is very important. Will the margin be heaped up or not? We read about heaped up margin in case of your gastric carcinoma or a malignant gastric ulcer, right? Margins will always be in level with the surrounding mucosa, right? That's important. There'll be no heaped up margin. It will be in level with surrounding mucosa. There's a classical finding here. So it will be exactly like this. It's just an ulcer. This, assume it's a surrounding mucosa. This is the punched out ulcer. It will be level. On the other hand, a malignant ulcer will have a margin like this. This is called a heaped up margin. It's heaped up. This is in level with the surrounding mucosa, right? Base. Since it's having, you'll have radiating mucosa reaching up to the tip of the ulcer, margin of the ulcer. That's also an important finding. Base. Since the primary problem is due to acid and pepsin, will the base be clean or it will have necrotic areas? Most likely be a very clean base because of digestion. The pepsin induced digestion of the base makes it very clean. If it's a cancer, there's more likely chance I could have some necrotic debris in the cancer, but here generally it'll be a very clean base, right? So these I want you to explain, because again, benign peptic ulcer versus a malignant gastric ulcer is a very important difference in a viva. Please explain this little bit in detail, right? Microscopy, you must have had in your college slides of gastric ulcer, right? Actually, no one will see the slides of gastric ulcer. It's a gastric ulcer. I know it's a gastric ulcer. That's all, right? You will not mostly have anything, right? But if you want to explain the microscopy of a gastric ulcer, you will have like a normal ulcer, right? Normal ulcer, I'll have loss of epithelium. Whenever there's loss of epithelium, by default, I'll have a necrosis. Loss of epithelium is nothing but necrotic, right? So the first layer, the topmost one, is going to be a necrotic area. Necrosis, which is nothing but the loss of epithelium. So whenever I have necrosis, can I say I'll have inflammatory exudate? You will have by default inflammatory exudate. It's an acute ulcer. Its ulcer is acute, right? So I'll have neutrophils. So I have necrosis. So surrounding the necrotic area or just below the necrotic area, you will definitely have your exudate. Okay. So will it start healing? It's ulcer. Any ulcer will definitely start healing. So below this necrotic area and the exudate, I'll have the healing area. What's a healing zone called as? Healing is your granulation tissue. Exactly below this area, slowly healing starts. So I'll have the granulation tissue here. What is granulation tissue made of? It's nothing but made of tiny blood vessels with little bit of collagen, right? Type 3 collagen, that's how it will be there. You might have a scar laid in the surroundings. Surrounding might have a scar tissue because the old ulcers or something. This is how an ulcer, an acute ulcer looks like, right? Bhavya, H. pylori has few of the genes called as CAG and VAC. Those are cytotoxins which are pro-inflammatory. Same, it's reactive toxin species induce damage only. On long term, they'll cause cancer. Fine. Okay. This is how a normal microscopy looks like. But no one does a microscopy. It's more than enough, right? So I know the microscopy as well. Complications is important. Can anyone enumerate what all ways an ulcer can complicate? Gastric ulcers and duodenal ulcers, any one of them. You will have chances of bleeding, right? Definitely there'll be chance of bleeding there. Bleeding will be there. Bleeding will be in the form of melena. Most likely in case of a duodenal ulcer. Bleeding may form hematemesis. Hematemesis is a little bit more common in gastric ulcer because only when gastroepiploic artery is involved, I'll have a huge source of bleeding. Melena is most commonly seen in duodenal ulcer. No major superficial arteries there. Tiny bleeding will be there. That's one. Cancer is by default. Gastric ulcer might not increase in size. Perforation can happen, right? Perforation can happen, which can result in rupture of the stomach, which is obviously an acute abdomen, right? It's an acute abdomen. You will have to immediately do a surgery. That also is possible. Okay. Stricture. Long-standing ulcers can definitely cause stricture because when I have ulcers again and again happening, every ulcer will heal by fibrosis. Over the period of time, it will form stricture. And malignancies. The chance of gastric ulcer becoming malignant is a little bit more. Okay, there's more chance of them becoming malignant than a malignant duodenal ulcer. I'm not saying duodenal ulcer will never have a malignant stage, very less or minimal, but gastric ulcer can have a risk of transforming into a malignancy, right? So these are the complications. Again, treatment, you have an entire chapter on how to treat gastric ulcers. Be at your own thing. If you feel that it's a very short answer for an essay question, add more on treatment. Make sure you fill up the extra half a page. That's it, right? Okay, that's about gastric ulcer. Today I covered within an hour. Stricture is nothing but recurrent fibrosis, Samantha. That's what stricture is, right? So what I'll do is I'll try. Is it okay if I can take a class between 3 to 4 p.m. tomorrow? Is it okay with you guys? If it's okay, can we cover liver tomorrow? A little bit of liver. Is it possible? If it's possible, do let me know. We'll try to complete it because I cannot compete with the 7 o'clock time. If I can take a little bit early and you'll have adequate time to go for the next class as well, right? Perfect. So we'll do one thing. I'll ask the team also to give me an extra slot. If they're not giving, I'll take in my YouTube channel. It's anyway on YouTube, right? So hopefully they'll give me a slot here. 3 to 4 p.m. We'll see liver. Fine. It's a chronic ulcer, right? Recurring ulcer again and again. It can produce fibrosis, which can cause stricture. That's what, Samantha. Okay. So thank you guys for your patient listening. So GIT slowly is done. Slowly one by one we'll complete it. Don't worry. By November end, we'll be completing everything required for you guys, right? Bye bye. All the best. Good night. Sure, Mish. I think you will answer that better than me. I have ultimate confidence in you. I'll ask you some leading questions. I want you to answer that, right? What does reticone mean? Can I say reticone means it's nothing but the response of the bone marrow? Yes, it is, right. If my bone marrow is going to proliferate more, reticone will become more. In iron deficiency anemia, I am not having enough nutrition for the bone marrow to grow. Do you think will bone marrow grow or not grow, Amish? It will not grow. I don't have enough food. No one grows. Bone marrow's food is iron. Iron is not there. Bone marrow will not grow. So the bone marrow is not growing. New cells will not be formed. So reticulocytes will not be formed. It's slow. But in thalassemia, it's a hemolytic anemia. Whenever there's a hemolytic anemia, what will be the response to the bone marrow? Hyperplasia. It's not only in thalassemia. Every hemolytic anemia, bone marrow will respond by producing more and more and more RBC, trying to replace them. If they are hyperplastic, what will happen to reticount? It obviously becomes higher. Fine. I hope you understood that. It's a very simple explanation. Reticulocyte is nothing but a marker of bone marrow's activity. That's all. Fine. DOG1 Yugesh. Dodge 1 is very specific for GIST. If it's about specific, we go for Dodge 1. Discovered on GIST first. That's what Dodge 1 means. Okay, great. See you guys tomorrow, hopefully by 3 to 4. Bye bye. Thank you.